Hey, welcome to our fifth RadPath lecture. Today we'll be talking about the adrenal gland. My name is Matt Hartman from Pittsburgh, PA. I'm a member of AMSR. Again, the full lecture can be found on the ACR building blocks site. We have an Anki deck of RadPath flashcards. And I encourage you to review the renal RadPath presentation before you try this lecture and presentation. This is based on a former RSNA presentation, and I'll be showing some of the highlights. Key thing to remember is adrenal lesions are very common. Most of them are going to be benign, though, of no clinical significance. But as radiologists, one of our main goals when looking at the adrenal gland and seeing a lesion is trying to differentiate benign from malignancy, especially metastases. So some helpful pearls as we evaluate adrenal lesions. Probably the most important one is clinical history. This is going to affect our pretest probability. We need to know if the patient has a known primary malignancy. It's also helpful to know if the patient has known increased adrenal hyperfunction. Are their VMAs elevated? Do they have hypertension? Number two, Hounsfield units are your friend both pre, post, and delayed contrast. Number three, fat in an adrenal lesion is also your friend and indicates a benign process, such as an adrenal myelolipoma or a lipid-rich adenoma. Number four, metastases fall under almost every differential for adrenal mass. And if you remember the first lecture, every Hartman differential, Mets and lymphoma. Number five, look for ancillary findings like IVC invasion, which can indicate adrenal carcinoma. Number six, if you have a large mass greater than 5 centimeters, be thinking adrenal cortical carcinoma. Number seven, if there's calcification, think inflammatory, old hemorrhage, adrenal cortical carcinoma, or adrenal myelolipoma. Number eight, do not forget PHEO. PHEO is our chameleon, can look like anything, but often has a high T2 signal. And again, knowing the laboratory values is imperative. If you have a high VMA, you have a PHEO. If they have not checked the VMA, it's often a good idea to check that before you go into surgery. Okay, let's talk about functional adrenal masses first. So our first will be, you have a high aldosterone level. So this is Conn syndrome. If it's caused by adenoma, that's 80%. 20% is hyperplasia. Cushing's syndrome, extra cortisol. In this case, 20% will be adenomas, and the others will be exogenous steroids, pituitary adenoma, or non-pituitary adenoma. Third, viralization, most often caused by adrenal hyperplasia, often in PEDS patients. And then the fourth, our friend, pheochromocytomas with catecholamine excess. We remember the rule of tens, and we remember to check for VMAs. So let's review CT density and apply it to adrenal adenomas. So adrenal adenomas can be lipid-rich, 70%, or lipid-poor. We can diagnose adrenal adenoma if on a non-contrast, your value is less than 10 Hounsfield units. Again, this assumes that you have a homogeneous lesion. We don't want to be measuring a large 5 centimeter centrally necrotic mass and call it adenoma. You know, for those cases, we're going to be worried about adrenal cortical carcinoma. But if it's homogeneous, less than 4 centimeters, we are good. But not all adrenal adenomas will measure less than 10 Hounsfield units on non-contrast scan. For these cases, where you do have a non-con and it's low density, we have the diagnosis, lipid-rich adenoma. But if not, we have to do washout. Now, this is a resident level topic, but I want to introduce it to the medical students. We can either have absolute washout or relative washout. This is a CT scan where you start with a non-contrast scan, get your Hounsfield units, wait 60 seconds, get your enhanced value, and then wait 15 minutes and get your delayed enhanced value. Let's see an example of this. here's the CT non-contrast, 15 Hounsfield units. It's more than 10, so we cannot call this a lipid-rich adenoma. It enhances to 80 and washes out to 24. Here's our formula. We get 86% washout. Our criteria was 60% or more, so we clearly have an adenoma and have excluded metastases. We can also use MRI to identify intracellular lipid. We'll use something called in and out of phase imaging to identify this intracellular lipid. And what we are looking for is we have T1 MRIs, the CSF is relatively dark. And if you notice for the out of phase imaging, we have this India ink artifact. So the way I think of this is we are becoming histopathologists with MRI. This is our stain for intracellular lipid. And we have a adrenal lesion here, which is gray. We do the out of phase imaging and it becomes dark. So this patient has intracellular lipid. This is a lipid-rich adenoma. Note the liver also becomes hypointense on out of phase imaging. We also diagnose a fatty liver or hepatic steatosis. This is in contrast to this patient who has breast cancer. Again, we have a gray adrenal lesion on in-phase imaging. Do out-of-phase imaging, it still stays gray. This was a metastasis. Again, the same patient, in and out-of-phase imaging. We lose signal on out-of-phase imaging. We diagnose intracellular lipid. We have a adenoma. Here's the algorithm for diagnosing adenomas. Again, you can do the non-contrast CT, you can do the washout, you can do the chemical shift MR. Sometimes you don't have an answer, and we either follow it or biopsy it. So to review, adrenal adenomas are very common, and we can diagnose it with a non-contrast scan, less than 10 Hounsfield units. We can do the washout on CT, or we can do the MRI with the in and out of phase imaging. So now we're going to talk about macroscopic fat. This fat will measure between -20 to -100 Hounsfield units on CT. And we remember our differential for fatty abdominal lesions from the first lecture. Lipoma, liposarcoma, renal angiomyolipoma, we saw that in the kidney lecture, adrenal myelolipoma, and teratoma. So here is a non-contrast CT. We see a large adrenal lesion, but we see this low density component to it, -40 Hounsfield units. This is macroscopic fat. This was a adrenal myelolipoma. Because it was so large, they decided to take it out, but path-proven adrenal myelolipoma. On MRI, we can also diagnose the macroscopic fat. This is a T2 image. Note the CSF is T2 hyperintense. The fat is also bright, but here we give them an instant liposuction with the T2 fat sat. They lose the sub-Q fat, but look, the fat here, this T2 hyperintense signal in the adrenal lesion also becomes more hypointense. We diagnosed macroscopic fat in this patient as well, adrenal myelolipoma. Here's a fun case. This was an oncology patient with lots of findings. We'll start with the adrenal glands. Bilaterally enlarged masses, both of them. But look at the kidneys. We should be in the nephrographic phase, should be nice and homogeneous, but instead we have multiple masses. Every Hartman differential, weight loss, night sweats, that's lymphoma. This was a path-proven case of lymphoma. Here's the ultrasound showing multiple hypoechoic masses in the kidneys. The Mets and lymphoma go into almost every differential, especially if you have bilateral lesions. And for this case, tissue is the issue. If it's metastases, you have stage 4. If you have lymphoma, you have a cancer, you have a process which can respond very well to chemotherapy, as it did in this case. So making that diagnosis is imperative. So here's another case, like MRI. Let's go through it. We have a T2. CSF is T2 hyperintense. There's no fat, so the fat has been saturated out. The fat is low signal here. We have T1. CSF is hypointense. And then we give contrast. The aorta lights up. What else is lighting up? This adrenal lesion right here, which is also T2 hyperintense. And if you remember our pearl, the chameleon, think pheochromocytoma. You note that they also scan the T-spine. And we get an enhancing lesion in the mid-thoracic spine. There's a cystic component. This was a hemangioblastoma here. This is a pheochromocytoma, elevated VMAs. And this was a patient being followed in the von Hippel-Lindau clinic. We remember von Hippel-Lindau disease from step 1. It is associated with a tumor repressor gene and has increased chances of getting hemangioblastomas in the CNS, like this case, renal cysts and renal cell carcinoma, pancreatic cysts, and pheochromocytoma, like this case. So adrenal lesions. Remember, fat is our friend. Remember mesolymphoma for each case. And remember to know, ask yourself, does the patient have a known malignancy? And does the patient have any signs or symptoms of adrenal hyperfunction? Thank you.